miscellaneous pathologies in the context of obstetrics. So essentially, we'll be covering severe asthma in pregnancy, respiratory failure and ARDS, liver failure and pregnancy, cardiac failure and pregnancy, and amniotic fluid embolism. Okay? So, pregnancy and asthma. It is the most common condition in the world. To complicate pregnancy, the main problem is that ventilation is going to be inhibited by the growing uterus, as well as a slight increase in airway resistance, which is a problem because asthma is a high airway resistance pathology. So you're making a high airway resistance problem worse, and your compliance is lower because there's something pushing from the bottom. Many of the drugs that are used to combat asthma may be contraindicated or counterproductive, like beta agonists in the later stages of pregnancy. Hypercapnia in the non-pregnant populations is something, unfortunately, that we have to tolerate when we ventilate these patients, is something that the pregnant mother cannot tolerate. In short, everything is more complicated. On the bright side, progesterone and relaxin tend to improve asthma usually over the first and second trimester because of the relaxing effect. There's more gastric reflux. There are more allergic exacerbations, particularly in the last trimester. There is less capacity to compensate. And as we said before, they are always at a bit of a higher resting respiratory rate with a mild respiratory alkalosis, which can confuse their presentation. The preload is already decreased because the preload is the blood that gets to the heart from the right side. So if you have something compressing your vena cava, you have less preload arriving to the heart, and you also have the PEEP that is making more impedance to the venous return to the blood on the right side. Prolonged maternal hypoxia can be associated with IUGR, and poorly controlled asthma is a risk for preterm delivery, like other things, such as malaria, instrumentation, whatever. But it is another risk factor for preterm delivery. Okay? The prompt recognition of acute severe asthma is critical. Consensus for the initial management remains the same both for pregnant and non-pregnant populations, and includes beta agonists, steroids, and anticholinergic agents. Patients with severe distress or unresponsive to repeated agonists are, per definition, in status asthmaticus, okay? Critical asthma. Additional treatment is available to enhance maternal and fetal oxygenation, such as magnesium, Heliox, leukotriene antagonists such as montelukast, IV, beta agonists. If all of this fails, then you have to consider mechanical ventilation and potentially extracorporeal membrane oxygenation, which is a very rare commodity not available in most countries, including my own. Even we in Malta do not have ECMO. We refer our patients to Sicily. So, non-invasive ventilation, so something with high flow or a fitting mask, can be very dangerous in this situation because of the risk of aspiration. However, intubating a pregnant asthmatic mother is not an easy decision to take at all. And because of these 4 points, it is very likely that unless you're prepared, your pregnant mother will crash when you intubate her, because we've already said they have a low preload. Their afterload is relying on their sympathetic drive at the moment. And the moment you intubate them, you remove it. She's been asthmatic in critical asthma for a while. So she's undergoing dynamic hyperinflation, and it's very hard to expel that trapped air from a very high resistance lung. And also, the high pressures can induce a tension pneumothorax. So this would be a template of how I would ventilate such a patient. I would go for lung protection, volume control. I would not allow the patient at any point to breathe spontaneously. They need sedation to be quite deep. You start off with 100% oxygen and you work your way down. PEEP needs to be targeted depending on whether you find intrinsic PEEP or not. And you aim for plateau pressures less than 30, something which is very hard to achieve in an asthmatic patient where their peak pressures can go up to 50. Okay? And the respirate needs to be slow because you need to allow expiratory time to allow for air to be expelled as much as possible. Okay? Unless you absolutely have to, you try to avoid adrenaline because of its placental vasoconstrictive effect. Intubated patients in asthma or ARDS or COAD tend to push their CO2 levels up. Now, in the normal population, we allow it. Permissive hypercapnia. In the pregnant population, we don't. Fetal hemoglobin will have a very poor affinity to oxygen, which will mean that the fetal unit will not get enough oxygen delivered to it. Okay? We try to avoid muscular blockade as much as we can. And always when intubating them, you remember that they can crash at any moment. Okay? As we said before, you avoid steroids in the first trimester. Beta agonists in labor slow everything down. So it's something you need to bear in mind towards the end stage of labor. Routine ICU sedatives can cross the blood-brain barrier, so they also cross the placenta. If the plan is to proceed to cesarean, remember that the baby will be born quite floppy, so it will need resuscitation. Okay? So there we covered the first of 5 topics. We covered asthma in the context of pregnancy. Now, on to asthma getting worse, respiratory failure in pregnancy. So essentially, you're trying to ventilate 2 circulatory systems right now, not one, the mother and the baby. And you're using one set of lungs, the mother's lungs, with a disease. So you're ventilating a complex adult with a fetus with its own brand of hemoglobin. Again, in short, everything becomes more difficult. Okay? You have to start looking for the causes. Why is the patient in respiratory failure? Is it because she received a spinal and it went too high up? That's why she's not breathing properly. So you'd look for abnormal diaphragmatic movements. They would be paralyzed from nipple down, consciousness preserved, and their CO2 is predominantly the feature of the respiratory failure. So is it a high block? Is it an amniotic fluid embolus? You see signs of heart failure, petechial rash, seizures, and hemodynamic compromise. The mortality rate of AFV is extremely high. Is it preeclampsia, which we've talked about for ages before? Is it something wrong with the heart? Is it a peripartum cardiomyopathy? A rare occurrence, but can happen. Did you give your patient too much magnesium? Do you have absent reflexes? You have clinical features of hypermagnesemia. And this is why the patient is in respiratory failure. Her respirate has slowed down because of this. Okay? Is she septic? Is there a pneumonia? Or has she been given too much analgesia, peripartum, and she's now becoming a little bit intoxicated with the opiates? Did she get a PE? We said that our patients are at an increased risk of thromboembolic events, so you always have to have an index of suspicion. Did we give too much fluid and we overloaded the lung? Remember in the first lecture, we said that these patients are at an increased risk of aspiration because of the relaxed sphincters, etc. Did she aspirate? Or did she get a transfusion reaction from the blood we gave her in treating the hemorrhage? So, as you can see, quite a few reasons why a pregnant woman could go into respiratory failure. Okay? How to manage them? You need to maintain normoxia, as we said before. You cannot tolerate permissive hypercapnia, as we said before. Intubation will be difficult, pressures will be high, and prone ventilation is not possible. Because whether she's pregnant or fresh from a cesarean wound, treating her in the prone position is going to be difficult / impossible. Okay? Airway, we said we prepare for a difficult intubation, and the most senior person in the room should be doing this intubation. Settings similar to what we said for asthmatic patients, ensuring lung protective ventilation. Ensure cardiovascular filling is well maintained, as well as not giving too much fluid to cause capillary leak into the lungs. We avoid long-acting opiates and benzos to protect the fetal respiratory drive and the fetal well-being. Continuous CTG, early ONG, neonatology involvement, because you have to start considering delivery at the first available opportunity. Okay, so there we covered the asthma and respiratory failure from what you can see, many reasons. Liver failure in pregnancy. HELLP syndrome we've covered. But HELLP syndrome is not the only reason why the liver in a pregnant woman will derange. In fact, the non-specific LFT derangement in a pregnant lady who is unwell is quite a common scenario. She has a high blood pressure. She may or may not have had seizures. She may or may not have had a temperature. And she may or may not be receiving drugs. In short, quite complex. And so, why is this patient jaundiced and with an abnormal mentation? And here we'll explore a few of the possible causes. And I asked myself, I divided them into 4 categories. The first category is causes of liver failure unrelated to pregnancy. And she happens to be pregnant. Okay? Drug-induced hepatitis. Something like paracetamol or a history of overdose from a hepatotoxic agent, where we start treating with N-acetylcysteine, which crosses the placenta and has a protective effect on the fetus. All the more so because glutathione levels fall in pregnancy, so you will need NAC to replace it, even more so than the non-pregnant population. If they decompensate to FHF, fulminant hepatic failure, you manage them accordingly. Okay? Is the cause for the liver failure shock or hemorrhage? An ultrasound would show us a normal liver. And the LFT derangement allows resuscitation for severe PPH, your higher AST and higher ALT. So it's your transaminases that go up, not your cholestatics, not your gamma GT, not your ALP. It's your liver enzymes that go up. And it should improve after the shock is resolved. We had a patient it's before Christmas, so about 8 weeks ago, who had presented with severe dehydration and antepartum hemorrhage. It was a little bit of an abruption. She kept the pregnancy, but she developed mild liver derangement, which we found out was due to underfilling. We resuscitated her with fluids. The liver enzymes got better within 48 hours. The cause of liver failure, a decompensation of pre-existing liver disease. Was she cirrhotic before getting pregnant? Okay? Which means that she is at much higher risk of developing peripartum complications. You have to cirrhotic patient. Sodium control can be particularly challenging in cirrhotic patients. They tend to be hyponatremic, so they tend to retain lots of fluid. Okay? Number 2, causes of liver failure made worse by pregnancy. Viral hepatitis, so you need to check your hepatitis B and C serology. It is the most common LFT derangement in pregnancy, in fact. Usually blood pressure here control is normal, ribavirin, because it is a teratogenic agent. Okay? Is it some form of disease, either of the portal vein or the hepatic vein? Or is it cholecystitis, inflammation of the gallbladder or thickening of the gallbladder and stones because of pregnancy? So here, remember, we are dealing with causes of liver failure that are made worse by pregnancy, not unrelated. Okay? The LFTs now would show a blockage. It's your gamma GT and your ALP that would go up, not your enzymes first. Okay? And obviously, in this case, you have to consider whether surgery is the best option, because any surgery during pregnancy increases the risk of preterm delivery. Part 3, pregnancy-related causes of liver failure. So this time around, the failing liver is failing because of the pregnancy now. Emesis gravidarum, usually we think of it as a very mild, innocuous, harmless thing that women get in the first trimester. But if very severe, can be associated by a rapid rise in transaminases, followed by a rapid drop. Okay? So it's something to bear in mind that occasionally a very rapid rise in transaminases can be associated with hyperemesis gravidarum. Cholestasis of pregnancy, this would be characterized by a history of jaundice and itchiness. The ultrasound would show a normal gallbladder, but the LFTs would show a blockage picture. Okay? It can be managed with ursodeoxycholic acid and resolves rapidly with delivery, and is very likely to occur again in pregnancy, in the subsequent pregnancies, rate of about 60%. Acute fatty liver of pregnancy, a very severe form of liver failure associated with the gestational period. Presents with abdominal pain, vomiting, hypoglycemia, and coagulopathy. There are very typical liver findings on the liver parenchyma. Something that is not mentioned here, a very typical presentation of acute fatty liver is hypoglycemia. Okay? Quite a significant mortality. Delivery fixes everything, as it does usually in HELP, but it progresses very rapidly. So sometimes referral and liver transplantation may be the only option in these cases. Preeclampsia, which we've talked about, HELP, which we've talked about, these are two liver failure conditions that are actually caused by pregnancy. Okay. And acute hepatic rupture, which would be a complication of HELP. Okay? The fourth and last section, other causes of febrile jaundice coma with thrombocytopenia. So other causes of jaundice with a drop in platelets. Okay? And they're usually either hemolytic uremic syndrome, that is a triad of low platelets, MAHA, and a kidney injury. If you add fever and abnormal neurology, it becomes TTP. Okay? This is not HELP, because you're going to tell me febrile, jaundiced, altered consciousness, low platelets. Sounds like HELP. It's never seen in the first trimester. This tends not to get better with delivery, as HELP does, where you would have to consider things like plasma exchange and plasmapheresis. Okay? Sepsis with DIC, and the septic process can affect the liver significantly, in which case you have to rapidly and aggressively treat the source. So in short, we covered 4 things. causes of liver failure unrelated to pregnancy, causes of liver failure made worse by pregnancy, pregnancy-related causes of liver failure, and everything else, which is the hematologicals and DIC. Okay. We'll move on to cardiac failure in pregnancy. It is thankfully extremely, extremely rare. But it's a very complex patient to juggle between an obstetrician and a cardiologist. Pregnancy itself may precipitate a peripartum cardiomyopathy. Okay? And you have to determine whether it is a left dominant, a right dominant heart failure, or a biventricular problem. Okay? Peripartum cardiomyopathy, it is defined as heart failure developing within the last 5 months of pregnancy. It is non-familial and non-genetic. And you can only diagnose it if you've excluded all other possible causes of heart failure. Okay? It is usually a postpartum process, about 90% of cases. Usually, left ventricular function is the dominant problem, and the LV is usually dilated. Most of them get better within 6 months. And then obviously the management involves knowing the 4 things you have to manage: the management of preload, the management of afterload, the management of contractility, and advanced measurements. So when managing preload, you have to consider whether you give diuretics to your patients, whether you restrict fluids, or whether you need to start more treatment. Management of the afterload, whether you need vasodilators or something to help your right ventricle. Contractility, whether you need a contractile agent like DIG or dobutamine or milrinone, and advanced support. There are certain drugs which we know we can't use, and the family might need screening to look for other patients in the family who might have manifestations of dilated cardiomyopathy. The last section, I promise you, because you all look hungry and you need to go for lunch. So, amniotic fluid embolism. This occurs when some amniotic fluid gains access to the maternal circulation, usually in massive volumes and with catastrophic consequences. Death occurs usually due to circulatory collapse. And if that doesn't get you, it's your lung and the hypoxia that do. Quite a few risk factors for amniotic fluid embolism. The 4 most important ones are tumultuous labor, placenta previa, hypertensive disorders of pregnancy, and polyhydramnios. And there are others, of course. There's advanced maternal age, cervical lacerations, medical induction of labor, emergency delivery, smoking, diabetes, preterm babies, age over 35, and manual removal of the placenta. The onset of symptoms most commonly occurs either during labor and delivery or immediately postpartum. So during quite a panicky time, we're not talking about something that's calm and relaxed on the ward. Okay? It can start off very non-specifically with fevers, chills, nausea, vomiting, agitation, rapidly followed by a drop in blood pressure due to the shock to the cardiogenic system, hypoxemia, DIC, and neurological problems. So I could have removed everything and I just written disaster. Okay? Okay? Quite a few differentials again. Could it be a PE, which could give you a very similar presentation from a hypoxemia point of view? Could this be aspiration or anesthetic complications? Again, would present with severe hypoxemia. Sepsis, myocardial infarction, cardiomyopathy. Certainly we would get elements of cardiogenic failure there. Eclampsia, transfusion reactions. The one time I had a patient on table and I thought it was an AFE, she was prolonged labor, like 18, 20, 24 hours, and we went to theater because of fetal distress, We did her under spinal. Then she started losing consciousness, and we had to sedate her. We had to GA her. The uterus was very atonic, and the obstetricians gave carbaprost. Now, carbaprost is licensed to be given subcutaneously. They gave it intrauterine. The problem with giving, they gave it intravenous. Because obviously an atonic uterus is full of blood leaks, and they gave it then. She wasn't intubated actually at the time, because 2 minutes after they did that, she stopped breathing and she went into cardiac arrest. And we all thought, oh, AFV. So we started the AFV algorithm. I intubated her, etc., etc. And 4 minutes later, they tell me, we gave carbaprost intrauterine. Was that a problem? Thankfully, by the time we had given adrenaline, and she had reacted immediately. AFV would not respond to 1 shot of adrenaline. What she had was bronchospasm from carbaprost. Bronchospasm, which will respond immediately to adrenaline. So I think it highlights the fact that communication is very important. But I was a very junior doctor at the time, very shy, and I was sort of there doing as I'm told. I should have screamed at the obstetrician, but whatever. You learn. Okay? How does it happen? The amniotic fluid gains access to the circulation by several possible routes, either via the endocervical veins, or the placental insertion site, or uterine injury. And it goes in because you are applying positive pressure, pushing against the veins. And the vessels are empty. So there's exert a negative venous pressure. Okay? And one thing I want to make clear, that amniotic fluid is not this holy water bathing the baby, this wonderful fluid that is pure and clear like Mountain Dew. It's actually full of nasty things. There's fetal urine, fetal intestinal mucus, meconium, fetal skin flakes, lanugo hair, cholesterol, prostaglandins. It is the equivalent of injecting yourself with sewage. That is why you get such a profound response to amniotic fluid. And even if there is no meconium, it is still profoundly immuno-inducing. Okay? The hypoxia and the shock. The hypoxia is essentially due to a ventilation perfusion mismatch. It is literally like a PE event. You are unable to ventilate and perfuse your lung. And this process is made worse by the capillary leak and bronchospasm, similar to anaphylaxis. The shock starts off as obstructive. There's something actually physically blocking the output from the heart, which is then followed by distributive shock with a sepsis-like picture. These two will together lead to activation of complement and the coagulatory cascade, and you get rapid DIC. Okay? It is usually a diagnosis of exclusion based on strong clinical suspicion. Listen, it's an atonic uterus, and we've been pummeling it quite a lot. There is a risk of an AFV. Okay? There are tests you can take, but usually there's no time to carry them out. Supporting investigations, obviously, to help you deal with the problems rather than diagnose AFV itself. Thrombocytopenia from a blood count, an ABG for hypoxia, a transesophageal echo to look at the heart strain, etc. How to manage? It is very hard to treat, and the mortality here is extremely high. You have to maintain normoxia, so you ventilate with 100% oxygen, and if this patient is still alive, therefore, definite referral for ECMO procedures. You encourage pulmonary artery vasodilation with prostacyclins and nitric oxide, inotropes to maintain a satisfactory cardiac output, and also you try and decontaminate the circulation by plasma exchange or dialysis. Supportive management remains the mainstay. Intubation is likely to be required at some stage, sedation for tube tolerance, and house jobs we do in intensive care, attention to electrolytes, fluid resuscitation, bearing in mind the leaky capillaries we're dealing with, urgent delivery, activated factor 7A for DIC, reduced hemorrhagic complications, using TEG or similar devices. But perimortem cesarean may be required. 65% of cases occur before delivery. And on that very sad note, we are at the end of our presentation on the weird and wonderfuls of obstetrics. We covered asthma and how our strategies are limited by the pregnant uterus, respiratory failures, causes and management, the 4 different types of liver failure causes, something about peripartum cardiomyopathy, and that AFP is a ticking time bomb. Thank you. Questions? Okay, I think that brings us to the end of our obstetric symposium. Let me see. My target was 1 o'clock. No, it was midday. It's 12:15. So I've gone a little bit over time. Thank you very much for attending. If you have any questions, I will leave my email address with Adoma. So should you have any questions you want to ask, presentations as PDFs, if you'd like them. Yes, okay, I'll provide them. Thank you very much. You're free to go. So, best if you give me your email. They'll send them to you directly. Actually, you can keep it. It's fine, you can keep it. Okay, go on. Actually, better type it. I hope, I hope you like them.